Hi everyone. The eight of us have come together to prepare a presentation for you all to talk about a topic that you've probably noticed to be trending for quite some time, whether through media outlets or even word of mouth. The topic? Medicinal marijuana. The truth is that despite medicinal marijuana being a hot topic, there's a lack of evidence to support its efficacy in managing the different illness symptoms that people claim it to be good at. A huge contributing factor to this is that marijuana is still illegal at the federal level, and that makes it really difficult to obtain funding for research. So, until there are legislative changes, no legitimate research can be done. But hold on, don't be discouraged. Healthcare providers like ourselves can be the bridge for policy change and advocate for more clinical evidence. So let's go back to the drawing board. Before we move ahead, let's take a look at the historical context of marijuana use. For centuries, marijuana has been used for both recreational and medicinal purposes, and this is dating back to roughly 500 BC. And in the early 1900s, marijuana was introduced to the US for its recreational purposes. That's when it was labeled as a Schedule I controlled substance by the DEA. Still today, marijuana continues to be classified as a Schedule I drug. Just to remind you all, a Schedule I drug indicates that it has a high potential for abuse while serving no medicinal purposes. So, we're sure you can all understand why this has created the perception that health benefits of medicinal marijuana are insufficient. The FDA says that there has not been enough research conducted to show the benefits outweigh the risks, but it's pretty difficult to conduct research on the efficacy of a drug when it's considered to be illegal. That brings us to a pop quiz question. What are the components of medicinal marijuana that are claimed to be the contributors of disease symptom management? Good job, you guessed them. CBD is a cannabis compound that claims to result in health benefits without causing people to feel high. THC, on the other hand, is also said to improve health benefits, but produces that euphoric high that kind of makes medicinal marijuana stigmatized. Medicinal marijuana contains both components, but there are strains that are CBD rich and others that are THC rich. Now that medical marijuana is currently legal in 29 states, the FDA has approved a few THC and CBD containing medications. An example of a THC rich FDA approved medication is Marinol. This is starting to make the public question, should marijuana even be considered a Schedule I drug? So why even give medicinal marijuana all the extra attention when there are plenty of medications out there that are not Schedule I and are actually made for managing the same symptoms that they claim medicinal marijuana is effective in? Well, these individuals are typically those who have tried everything else and have turned to medicinal marijuana as a last hope. It is actually said that medicinal marijuana has been effective in alleviating the symptoms of a range of debilitating medical conditions. Some examples include preventing weight loss due to poor appetite in those with HIV or AIDS, improving cognitive function and muscle stiffness or spasticity in those with multiple sclerosis, managing chemo-induced nausea, controlling seizures and epilepsy, and managing high-level chronic pain when nothing else has been effective. Medicinal marijuana is actually said to be an effective alternative to narcotic painkillers, thus reducing the amount of narcotic prescriptions. So that brings us to two relevant Healthy People 2020 goals of 1. Decreasing resource use among adults with chronic pain who use an overabundance of healthcare resources such as provider time, number of providers, emergency room visits, and abuse opioids, and 2. Improve the quality of life of cancer survivors. If medicinal marijuana is truly effective at managing things like chronic pain or symptoms like nausea or even uncontrolled seizures, then an abundance of its use could greatly impact the likelihood of achieving these goals. 3 other relevant Healthy People 2020 goals are increase shared decision making between patients and providers, increase providers involved with patients in decision making about their health care, and increase healthcare providers who show respect for what the patient has to say. Providers need to foster a non-judgmental environment where patients feel open to explaining what they've tried and what they're open to trying. Let us emphasize that medicinal marijuana should remain distinct from recreational marijuana use. As providers, we do not want to promote substance abuse, especially among adolescents. So as we mentioned earlier, In order to show the efficacy of medicinal marijuana in managing symptoms and illnesses, there really needs to be more clinical research. And just to emphasize what we've been explaining about the lack of available research, we searched Cochrane database regarding medicinal marijuana use for managing 3 different symptoms, and here's what we found. In regard to neuropathic pain management, Cochrane actually doesn't have a systematic review available, so one is recommended due to the contrary conclusions between present reviews. For chemo-induced nausea and vomiting, Cochrane finds that the quality of evidence has methodological limitations and there's a lack of recent random control trials to reflect current chemo regimens. And with regard to epilepsy, Cochrane recommends further trials. They claim that the present trials have small sample sizes and short study periods. So, what's the bottom line? We need more evidence. So, what can we do as providers? Well, advocating that marijuana be changed from a Schedule I to a Schedule III drug will increase the amount of clinical trials and evidence to show whether or not it's effective. Because marijuana is classified as a Schedule I drug, those who use or distribute the product can be held criminally liable. If it were to be changed to a Schedule III drug, on the other hand, it would fall into a class that's defined as having a lower potential for abuse than drugs in the first 2 categories, along with accepted medical use and only mild to moderate possibility for addiction. Despite there being some FDA-approved medications containing THC and CBD, there is limited information on hospital policies regarding their use. Many hospitals receive federal funding and risk losing that funding if marijuana is used in their facility due to its Schedule I classification. Additionally, there needs to be some consistency between federal and state laws regarding prescribing. But we're moving in the right direction. There's currently a bill that was introduced to Congress in April of 2017 detailing a request to reschedule marijuana to a Schedule III. If this bill passes, more research could be done on marijuana and its potential medical benefits, and it would allow open banking to support growth in research. Or, this research could even prove that marijuana doesn't really have an impactful medicinal value. Either way, allowing research to be done would be beneficial as more states are passing laws to allow its use. It is important to know the evidence and health impact of marijuana on our population. Now take a moment to look at where marijuana falls on the drug scheduling in comparison to the Schedule II drugs. The opioid crisis was just declared a national public health emergency under federal law, yet marijuana is scheduled at a higher risk level than those other drugs. In the state of Washington, there's a law that specifically describes the authorization of medicinal marijuana by healthcare professionals. It details guidelines on patient education requirements regarding its use, the type of illnesses it can be used to treat, as well as the documentation that is required to uphold state laws. For example, in Washington state, we are only allowed to suggest marijuana containing products that have less than or equal to 0.3% of THC. Any stronger THC concentration is considered to be outside of our scope of practice and therefore illegal. Due to the differences between federal law and state law, it's important to refer to organizational policies regarding the use of medicinal marijuana in your patient's care plan. Let's not forget that the decision to use marijuana for treatment should be one that's informed and shared between the patient and the provider. While deciding with the patient if medicinal marijuana is an appropriate option, healthcare providers need to be prepared to answer questions of how medicinal marijuana differentiates from recreational use. Thorough discussion needs to review its risks and benefits. Patients should also be notified of the variability and lack of standardization of CBD and THC concentration within certain preparations. So in conclusion, media, along with the legalization of medicinal marijuana in some states, has created a trend of increasing use of this drug. However, there is a need for policy change and clinical evidence regarding marijuana's effectiveness and use. Unfortunately, without federal changes in regulation and rescheduling of marijuana, it's impossible for clinical control trials to be funded and conducted. It is on us, as future providers, to advocate for changes that could have potential benefits to our patient population.